Thank you for attending today's webinar, BMI and Online Adolescent Self-Management. Please help us take account. If you are viewing as a group, please go to the chat window and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Just some reminders, all attendees are in listen-only mode. We want to hear your questions. To ask a question during this session, please use the chat tool that appears on the bottom of the right-hand side of your control panel. At the conclusion of the webinar, we request all attendees to complete the evaluation poll questions that will appear on your screen. Please let us know how we are doing and any new topics that you would like for us to cover. This webinar is being recorded and will be archived on our website. You may access the archived webinar and PowerPoint slides within a few days by visiting www.sbhforall.org/webinars. We expect that by the end of this webinar, you will have an understanding of West Virginia Department of Education's efforts to increase West Virginia health check exams, inclusive of BMIs, gain knowledge of pediatric policy guidelines, and 5210 for prevention and treatment of pediatric overweight and obesity, and understand implementation of healthy lifestyle survey, motivational interviewing, and goal setting into your workflow. Before we get started, we're going to launch a poll. Our first poll question for all attendees is, what role do you play in school-based health? Please use the answers below, administrator, provider, data manager, school nurse, or other, to respond to this poll question. Great. Thank you for sharing your answers with us. It looks like 5% of our participants are administrators, 39% are providers, 0% are data managers, 29% school nurses, and 26% other. The panelists presenting today will be Paula Fields, who is the Community Schools Coordinator for the West Virginia Department of Education Office of Special Programs. Children's health has been the focus of Paula's career for over 15 years. She holds a master's degree in nursing education and administration and has a wealth of experience in planning, starting, and technical assistance for clinical services, including school-based health centers, rural health centers, and other outpatient services. She is currently on the board of directors for West Virginia Medical Clinic. Paula has a diverse background in intensive care, cardiac rehabilitation, administration of outpatient medical clinics, including infection control, risk management, and performance improvement. Secondly, Stephanie Montgomery is a data manager with the School Health Technical Assistance Team at Marshall University. Stephanie has 20 years experience in working with West Virginia school-based health centers. She has assisted with the development of various software programs to collect information for the various medical, mental, and oral health school-based programs. Using data exported from the programs, Stephanie produces site-based and statewide reports. Lastly, we have Mary Grandin, who has worked in primary care and school-based health for the last 10 years. She graduated from Alderson Broaddus College in 1992 with a Bachelor of Science in Medical Science. She currently works for Cabin Creek Health Systems in one of their school-based health clinics and for Marshall University School-Based Health Technical Assistance Team as clinical coordinator for the school-based health centers around the state. She has helped with the expansion of school-based health within Cabin Creek Health Systems and has participated in quality improvement projects with the state as well as with School-Based Health Alliance. She has also served as president of the West Virginia School-Based Health Assembly and has worked on statewide expansion for school-based health centers. And without further delay, I am now going to pass it over to our presenters.
I hope everybody can hear me. Please let me know if you all can. And thank you all for joining our webinar today. We'd like to describe a little bit about our self-management system for adolescent healthy lifestyles that we've developed here in West Virginia as a way to identify and work with children who fall in that obese category and to decrease a little bit of frustration as you do that. So Marshall University's Technical Assistance Center is the place to go for resources, technical assistance, training related to school-based health centers, school-based health behavioral health programs, and school-based oral health programs in West Virginia. We've been assisting school-based health centers in West Virginia since the initiation began in 1994. So what we came to talk a little bit about today was our obesity, and I'm sure as some of you during the poll I noticed were providers, so you've probably seen these slides over the years. You almost can't go to any talk on obesity without a few slides that show how it has trended over the last several years. So, and as we've watched these continue to grow and the colors of the rainbow change, we've also seen it trickle down into our children. And this is what we've began to see over the years. And as we tried to decide how to tackle this, we began an education campaign. And what we found was our children continued to get heavier and heavier over the years, and our BMIs continued to increase. So, what do we do now? We continue to get bigger. Is it the way we look at obesity? Is it because we don't know how to categorize that? Is it a chronic health disease? Is it a diagnosis? You have diagnoses like diabetes, hypertension, hyperlipidemia, coronary heart disease, stroke, sleep apnea, gallbladder disease, osteoarthritis. All of these are affected by obesity. So how do we treat this, and what does it look like? Over the years, the chronic care model that we use to treat diabetes or high blood pressure or some of those other chronic diseases, some of you may notice that in this model you see the self-management support. And at the bottom here, you also see productive interactions. You have an informed, active patient and a prepared practice team who's there to help address this. What we found with our diabetes education over the years and using this model, we've watched diabetes care transform. We've seen it become more of a self-management type system, and it has seemed to improve our outcomes over the years. So that shift in our treatment paradigm, where the patients actually make the agenda when they're ready to change, is one of the things that needed to happen over the years. So you have universal assessment of obesity and their risk. And those of you who have EHRs and those kind of things, you'll notice that in some of those they have a health quality management section. And in those, you'll see those UDS measures. And this is one of those that we need to be able to address, is how do we tackle that UDS measure? We need to identify that population that is at risk, calculate and plot that BMI at every well child visit, and then make a plan based on the patient's motivation, their BMI category, and risk factors. We need to assess those medical risks, the behaviors that the patient has, their attitude, and all of that has to be done in an office visit. So identification and recognition of where that BMI falls and what risk that child holds in light of their lifestyles, their habits, and their family history risks. So this one I'm sure you all have seen as well, the basic definitions of the body mass index and how we come to the conclusion of whether or not children are underweight, a healthy weight, or overweight. Those that fall in that 85th to 95th percentile are considered in the overweight category. And as you think about your patient population that you treat every day, how many kids do you see that fall into that overweight category? Over the years, I've watched my patient population shift so that I have more and more children that actually fall into that overweight category. Once we reached a certain percentile in adults, they then had to go on and make another category for obese. So we, in children, also see that same category, greater than the 95th percentile fall into the obese category. And BMI has been correlated with obesity-related comorbidity conditions as well. If the BMI overweight and risk factors are present, such as acanthosis, family history of early coronary artery disease, then we need to go ahead and continue to look at the patient's behavior risks, the patient and the family concerns, and start a treatment plan. So how do we do all that? Most offices, when you begin to look at the treatment of these patients, you'll notice over there in that corner it says Stage 1, Prevention Plus. That's all done within the primary care office. And if you have a busy practice, like most primary cares or school-based health centers, you have about 15 minutes to do all of this visit and to do all this prevention that you're supposed to do for the well child and tackle all their other risk behaviors. So how do we do all that? In that 15-minute protocol, you're supposed to tackle obesity prevention with the assessment. You're supposed to set their agenda, assess their motivation, summarize, clarify goals, all of that within 15 minutes. Sounds pretty easy when you look at it on paper, right? So by this point, how many of you have felt a little frustrated trying to figure out exactly how you're going to do this? In Stage 1, when you look at it, this is the Prevention Plus model and what you're supposed to go over there in the primary care office. You're supposed to look at the dietary habits and their physical activity. Those are the two things that the UDS measure looks at. So reviewing their 5-2-1-0, which is their 5 servings of fruits and vegetables, 2 hours or less of screen time, 1 hour or more of exercise, and 0 sugary drinks. Then you're supposed to go over behavioral counseling, looking at their eating breakfast daily, limiting meals outside the home, family meals, are they doing that at least 5 to 6 times a week? Allowing children to self-regulate at meals without overly restricted type behaviors. And then you're supposed to set some goals. Weight maintenance with growth resulting in decreased BMI. Then have monthly follow-up. After 3 to 6 months, if they have no BMI change, then you're supposed to advance to Stage 2 treatment. So when you look at what Stage 2 treatment entails, dietary habits and physical activity again, plan for that balanced diet, emphasize low amounts of energy-dense foods, increase structured daily meals and snacks, supervise active play at least 30 minutes a day, screen time 1 hour or less a day, and increase monitoring by the provider, the patient, and/or the family. More frequently if you need to. Then again, you're supposed to goal set with these patients. Weight maintenance with decreasing BMI. Weight loss not to exceed 1 pound per month in ages 2 to 12. And then average weight loss of 2 pounds per week in older children and adolescents. They need to have monthly follow-up. And then if no BMI improvement, then we'll advance on to stage 3. So I'm going to turn it over to Paula now because she's going to talk a little bit about the education part here in West Virginia.
Hello, and this is Paula Fields from the State Department of Education in West Virginia. And whenever we talked, we thought that it might be nice to share a little bit about what education is doing to really encourage the BMIs. So we wanted to talk to you about Kids First and just provide a real quick overview to give you some thoughts at a state level of how we might be supported from the education perspective and really encouraging those partnerships with the medical community. Kids First began as a pilot here in West Virginia in 2007, and basically its purpose was to establish a comprehensive school wellness screening through the medical home concept. And at the table were some major payers that represented about 85% of our insurance, of our children who were insured. From that, we were really moving from the transition of the model for school entry from roundup, meaning no more mass screenings. We were referring them back to their primary care provider or their pediatrician for their well child exam. And here in West Virginia, we call that our EPSCT. And since we have implemented the Governor's Kids First, which is a comprehensive physical exam on school entry, either pre-K or K, pre-kindergarten or kindergarten, there has been an increase in 22% completion for our Medicaid-eligible children. So that means that we still have some gaps, but they are seeing their primary care provider where that BMI can be done, and they can have the interventions that should be done from prevention all the way through versus it being in the education system and not with the expert being their primary care provider or pediatrician. So we're really working across state agencies to adopt this as a way of doing business. And just wanted to show you what we currently are doing, and that is we have are working to increase the requirements for our well child exams for our students going in 2nd, 7th, and 12th grade. And our policy is on public comment at this time. And on the screen you'll notice the link is up, but you can just Google West Virginia Board of Education policy, and you'll see those are on public comment. We're often asked why grades 2nd, 7th, and 12th were chosen, and we have dental exam requirements already in place for that. And that tends to correlate with the ages that the students need immunization. So it's a start. Ideally, it would be every year all students have a comprehensive physical exam, but this is where we are moving our students back to primary care provider or their pediatrician for that expert level of care versus massive screening. So some of the benefits we've seen is that established approach to providing comprehensive primary care. Again, that's inclusive of the BMI with the related counseling. It really facilitates that partnership between patients, families, schools, and their healthcare provider. And it does provide that structure to work towards improved outcomes, working with that medical home. And it leaves the choice with the parents as to who the medical provider is and demonstrates working together, education and health care for all children. to work towards the healthy weight. So again, we really have moved away from mass screening with the rationale that that occurs during a comprehensive physical exam or EPSDT in West Virginia, and leaving that with a medical model. Just some statistics. This represents our Medicaid population, ages 0 to 9, and that's about 61% of all of our students. And you'll notice the participation rate to get a well-child exam when they're young is very, very high. 3 to 5 is higher than the remaining years, but it's still significantly lower than those first years. So we're hopeful that we can see an improvement in not only the 3 to 5, but also the 6 to 9, 10 to 14, and 15 to 18, similar to what we did the first year that Kids First was phased in, when we had that 22% increase. The next slide is our current West Virginia State Superintendent of Schools, and he really does have a one voice, one focus with all students achieving, and he recognizes that everyone within the community must support the schools and the students. And that's the premise that we talked to you about today, in that it's the partnership between what we call the meds and the eds, being the medical experts and the education experts, and working together where we each are stronger to make the strongest partnership for the best outcomes for our children and of course, our students. With that, I did want to just provide some contact information. At the end, Stephanie and Mary's going to share some more about how they're actually addressing the BMI in the school through the school-based health centers, and know that you can contact any of us, and we'll link you with wherever we need to go. So with that.
So over the years in doing this work and working with Marshall University, this is kind of where our story began, is how do we treat this? As healthcare providers, we saw this trend increasing. We tried to figure out how to change it. Like I said earlier, we watched it continue to increase. No matter how much education we did or what we tried to do, we continued to watch our state get bigger and bigger, and the colors change in the wrong direction. So exactly what did we decide to do with that? With Marshall's work on the adolescent self-management, they developed a team to actually sit down and kind of look at this. What were we going to do? How were we going to tackle this? So they searched chronic disease self-management principles and as applied to the adolescents in literature to try to figure out what's the best route to tackle this in our adolescent population. In 2007 and 2008, we talked about what type of tool would help facilitate this work. What could we do to help our adolescents achieve this? So they created a tool to facilitate adoption of healthy behaviors with a focus on food choices and physical activity. A social marketing tool, Nemours Foundation, the 5210 message, was what we used for that foundation initially, which is the 5 servings of fruits and vegetables a day, 2 hours or less of screen time, the 1 hour of physical activity, and none or almost none sugary drinks. When we originally started this work, we did it on paper. We thought, well, let's see how this works. Let's see how the kids respond to it. However, you know, kids in our technological day, they, the paper tool, as you see there, we got a little sad face. It just wasn't as efficient. The kids didn't respond to it quite as well. They did okay, but we decided to develop something electronic because they're always attached to their electronic devices. So the electronic version was then developed. We expanded, they revised the adolescent self-management software. Originally there was 3 surveys, which included the healthy lifestyles based on the Nemours 5210 clinical guidelines. There's also the CRAFT, which is the screening for substance abuse, that came from Boston, actually. And then the risk assessment, which is similar to the GAPS, but was modified to use in West Virginia school-based health centers. So as we did this work, we could actually have the student take any of the 3 surveys, depending on what we wanted to assess from them. If we had already plotted them on their growth chart and realized that they fell into that obese category, or even in the 85 to the 94th percentile, the overweight category, we realized that we needed to start working with those kids as well. So when we first did it, we decided to start with a small population of maybe 10, 12 kids to see how it worked, to see how often would we need to bring them back, and exactly how we needed to screen them. The risk assessment over the years was developed to identify all those other risks, not just their food habits, but their seatbelt safety and all of those. So over the years, it was eventually developed into the electronic version as well. The kids really seem to enjoy doing the electronic version. It doesn't take them any time at all to sit down and do this program. And then the provider on the other end has all the information. It doesn't take me in my health center, it doesn't take me as long to assess the student and ask all the questions, because they did that on paper while they were sitting in the waiting room for a few minutes waiting for me to come back out and bring that student back. With the healthy lifestyles, we looked at lots of different ways to, once we got the information, how did we develop that action plan then? And as Stephanie will address in the next few slides, it'll show you how we began to develop that process of action planning with the students and figuring out exactly how to change the outcome. So Stephanie, I'll turn it over to you.
So this is what the student and the provider will see once they're logged in. There's a login screen that the student, someone from the site will enter a username and password. We don't provide username and passwords to every student. We only provide a username and password to the site manager who logs into the program. The program is housed on a secure server at Marshall University, and because we don't get any identifiable information, we only get the student number. We don't have any issues with confidentiality. We developed some scratch pads for the provider to use that has a spot for the student ID. They assign the student ID and keep a record for the students so they can use that same ID each time they log in. It has their current measurements for the day, including their height, their weight, their blood pressure, and which of the 3 surveys the provider would like them to take that day. They can take 1, they can take 2, or they can take 3. But when the student comes to start the surveys, this is the screen that they see. So in the upper left corner, it defaults to student. They'll enter their number, and the visit date will automatically come up. They'll enter their date of birth, their age, gender, grade, height, weight, and the BMI and BMI percentile is automatically calculated for them. It's also grayed out so that they're not able to have any effect on the calculations, the BMI or the BMI percentile. They enter their systolic and dystolic blood pressure as recorded on the scratch pad that we provide to sites who are registered to use the program. The next thing they'll do, especially on their first visit, is they'll click the button that they want to take a survey, and the names of the 3 surveys, the healthy lifestyle, the craft, or the risk assessment will come up as buttons. And for the purpose of today's demonstration, we're just going to look at the healthy lifestyle. So the first question, there's a series of 12 questions with this one. The first question focuses on eating, how many servings of fruits and vegetables they eat on most days. So the statement is there, I eat 5 or more, which is the recommendation. They answer yes or no. And whenever they click on the yes or no button, it will automatically move them to the next slide. At any time, they can go back using the back green arrow, or they can restart, or they can cancel. You'll see that the student ID number is in the upper left corner, and the visit date is up there as well. When they finished all the answering all the questions, and these are the questions that are included in the healthy lifestyle. With each of our surveys, the very last question that is asked is, do you want to take steps to be healthier? So that's the very last question on each of the 3 surveys. We're hoping, and of course the majority of the students do answer yes. If they answer no, a little box pops up that thanks them for taking the time to do the survey and to discuss with their healthcare provider how they can take those steps to be healthier. The risk for the student version actually are printed out in black. What I did because we're not actually using the program, these are just screenshots, I went to the provider review section where the provider can put in the student's number, the survey they took, and the date, and then the risks are identified in red for the provider. But for the student version, everything is recorded in black, so they're not alarmed by some being red, some being black. The student will print 1 or 2 copies of the results of their survey and use this to start the discussion with the school nurse or with their healthcare provider at the school-based health center to start the conversation of how they can take steps toward a healthier lifestyle. This review button, of course, this is the provider screen that we have up now, but the provider can review each of the surveys by clicking on the review button, entering their initials, and it will indicate that it was reviewed that day and time by someone within the office. And we had that built into the program, particularly for the other 2 surveys where questions about substance abuse, depression, suicide are asked. And we feel it's very important before we ever release this program to someone that we know that they have a system in place to review the students' responses before they leave and to make the to take the necessary steps should any indication that they're a risk to themselves or someone else be evident. That's not going to happen on this survey, but I just wanted to give you a little bit of history as why that review button is there. Once the student closes out of the survey results, this screen comes up. And when I did the survey for the screenshots, I indicated that everything was a risk so that you could see the action plan items that would come up if a student indicated by their response that they had a risk in any of the healthy lifestyle areas. So if they only had one risk, that say they didn't eat breakfast every morning but everything else was in order, only the eat breakfast action plan item would come up for them to select. If you're familiar at all with self-management, you know that it's best to choose one item to work on and do your best with that before moving on to another or trying to work on multiple issues at one time. So for the purpose of this program, we asked the programmer to only allow the student to choose one action plan item per visit. And then within the program, they can come back on a number of days, update how they're doing. They can close their action plan and move on to something else. And we also have built in there why they chose to close their action plan. Did they meet their goal? Are they just tired of working on this issue? Or did they just feel like working on something else? This is what the action plan looks like. And so for the purpose of consistency, I had selected that I want to work on eating more fruits and vegetables. So the recommendation of what is a good day, eating 5 or more servings, the statement is there. The student gets to select what they currently are doing, how many servings they would like to add, when they will do that, and they can actually select more than one of these. Who can support them? They can select more than one. And then this, how confident are they that they'll succeed in meeting this goal of working on adding more fruits and vegetables? So they save and exit. And this little button up here, should they look at this action plan and say, you know what, I really don't think I'm going to work on this now, if by hitting this little orange button, it will take them back to the risk, the identified risk, and they can select something else. But once they complete this, they can save and exit, and then their action plan comes up for them to print out and also include with their survey responses to start the conversation with their provider. So at the top is the student ID, the date they took it, their age, grade, everything that they entered on that first screen is at the top of every action plan. On subsequent visits, this little graph would indicate the change over time. And then I couldn't get the full screenshot, but you can see the idea of how this report will print out whatever the student entered on that action plan, what they currently eat, what they hope to add, who will help them, and how often they'll do it. So they print this out, and then when they close, they're taken back to the home screen, and the question is asked to them, what do you want to do today? At that time, they can exit the program, or they can go on and take another survey. But you'll see up here, too, that currently the action plan is checked to show. The student can also leave this screen and show their measurements. At this time, only the measurements over time would show. They can print that out. They can also show their survey results if they need to look at that again. So they close it out, and before they leave, someone reviews the paper. If there's an issue, then it can be addressed immediately. Otherwise, the provider at her own time can log in as a provider, pull up that student ID, that visit date, and show that she reviewed all the information. So that's it for the healthy lifestyle. The craft, we just wanted to show you as part of the one of the 3 surveys is just these questions dealing with alcohol or drugs. And so it asks these questions, and then at the very end it also asks the question about, are you ready to take steps toward a healthier lifestyle? They can also build an action plan on how they plan to make changes toward a healthier lifestyle. And the process is the same. It would print out a copy of their survey and also a copy of their action plan. Same process, they can go in and update however often they want to their progress in making changes. They can close out the action plan and work in something else. The risk assessment asks questions. similar to GAPS, but we added some extra ones as well on oral health. Goal setting has to do with academic goals, and then the same process. The survey's printed out, they can work on, build an action plan. On our website for the Technical Assistance Center, we have a folder on Adolescents Health Management Online. This information is in there. We provide instructions for the provider. We have instructions for the student with screenshots on how to get through the program. There's also some information there on school-based treatment recommendations and just this whole self-management framework. So that's available for anyone to view or to download. So you might be thinking, I'm interested in using this program, and we are certainly agreeable to sharing the use of this online program in the future. Right now, we're still working with the programmers to build a backdoor feature that you as the user can export the information from your particular site so that you can use it for further analysis. Right now, me as the data manager can access everyone's information in an Excel file, and we're working with the programmers so that you as the user could do that too. So until we have that in place, we're not opening it up and sharing it. One thing that we do require before anyone uses it is that they fill out this request that we built in SurveyMonkey, and it just tells us a little bit about yourself, your program, how you hope to use this, and tell us a little bit about the system that you have in place to address any issues should they be identified on a visit. So even though we're not sharing it right now, you're certainly welcome to fill out this request, and as we complete this export, we would be in contact with you and discuss how it might be best used within your circumstances. This is our contact information. Paula provided her information for the Department of Ed, and this is our information for the West Virginia School Health Technical Assistance Center. We'd like to give credit to the Claude Worthington Benedum Foundation for providing financial support over the years to school-based health centers and to developing this program, and it was developed by Codebusters. So that's it. We'll be glad to take any questions.
Thank you so much to our panelists. At this time, we are ready to take your questions. So if you would, please use the chat box that's in the lower right-hand corner of your GoToWebinar control window, and we'll give you a few minutes to type those questions in. While we wait for your questions to come in, we just want to give you a little bit of information about what's happening in our organization. Upcoming in June 16th through the 19th, we have our 20th convention, which will happen in Austin, Texas. We encourage you and hope that you will register to attend and join us there as we celebrate 20 years of collective impact for student success. We also encourage you to become a member of School-Based Health Alliance if you are not already. We are a membership organization, and we rely on members to support our work as the national voice of school-based health care. We have two types of membership. They are individual and organizational. And to learn more about membership benefits or to become a member, please visit the Engage section of our website at www.sbhforall.org. We'll give you a couple more minutes to put your questions in. Okay, our first question is, are the monthly follow-up obesity visits billable, and how are they charged?
This is Mary, and that's a good question. Over the years, we've struggled with that in our own health centers. That's why I think it's probably one of the more frustrating things to tackle, because they're not unless they have another type of chronic disease. So that slide that I showed about whether is it a diagnosis, is it a chronic disease, how are we classifying it, I feel it should be classified just like all the other chronic diseases, just for that reason, because it takes a lot of time and effort on the provider's part and the patient's part to do this type work. They want to make that change, and I have found in my practice that over the years, if they don't have sort of like a cheerleader on the other side, you as the provider to help them, that they, like all of us, when we lose those champions around us to help us, we kind of fall off and go back to our old ways. So to answer your question, no, those monthly visits aren't unless there is another type of chronic disease associated with it. So have they already developed high blood pressure, or have they developed hyperlipidemia? You'll notice that one slide that had the steps to follow, and one of those is laboratory workup. So have you checked those labs, and do they fall in a category of hyperlipidemia? Most of the kids do have some other risk factor. I have several that have high blood pressure, and so there is usually another type of billable something throughout the time that I work with kids.
Okay. I'll give you a couple more seconds to put in any questions that you may have. Okay. So as some closing reminders, this presentation has been recorded and will be archived on the School-Based Health Alliance website within the next 2 to 3 business days. For more information and/or resources, please visit our School-Based Health Alliance website at www.sbh4all.org. And to request support and technical assistance, please feel free to send us an email at programs@sbh4all.org. At this time, we ask that you take a moment to fill out the poll questions that will appear on your screen. Our first poll question is, how well did this presentation meet your needs? Five more seconds to respond. Thank you. The next poll question. Would you recommend this webinar to others? Yes or no? Five more seconds. Thank you. And then our final poll question, how likely are you to apply this information in your organization? Five more seconds. Thank you very much. Again, thank you to our presenters today, and thank you all for joining us for this webinar on BMI and online self-management. Have a wonderful day.